Assalamu alaikum wa rahmatullahi wa barakatuh. Today we will speak about a new subject on pediatric surgery made easy. It's very important for all pediatric surgeon and pediatrician, which is inguinal hernia in infant and children. A very important subject, very common complaint in the outpatient clinic, and all pediatric surgeon and pediatrician should be aware of how to diagnose and how to manage this common problem and what are the operative approaches, what are the complications related to the repair, and if there is any special circumstances during dealing with inguinal hernia. Let's start. Inguinal hernia in infant and children. Very important subject. All pediatric surgeon and pediatrician should be aware of this problem in full details. Our items today will be a brief history about inguinal hernia. What about the incidence and the embryology? What about the risk factors? What about the association and how to classify inguinal hernia, how to diagnose, how to repair, and the special circumstances the pediatric surgeon should be aware. And finally, we will speak about the complications after the repair of inguinal hernia. Number one, brief history. The word hernia derived from Greek hernios, which meaning offshot or bud. The Egyptian Ebris Papyrus 1550 BC described the diagnosis and the treatment of inguinal hernia. Also, mummies like Ramses found to have inguinal hernia. During Roman Empire, Celsus described inguinal hernia treatment as a ligation and sparing the testicle in Diri Medica. The Galen described what's called processus vaginalis and defined hernia as a rupture of peritoneum. And he advised ligation of the second cord with sacrifice of the testicles. Arabic surgeon like Albucasis treating inguinal hernia by cauterization, and his technique adopted by some Western surgeons during the Middle Ages. Also, French surgeon Ambroise Paré described the ligation of the inguinal hernia in childhood, but advocate against the removal of the testicles. Following this, Passini described the internal inguinal ring tightening and reinforcement of the posterior wall of the canal, and the first laparoscopic hernia repair reported by Gere in 1982. What about the incidence of this problem? The lifetime incidence estimated to be about 5% for males. Males 5 to 10 times more than female infant. It's also inguinal hernia twice as common on the right side. Bilateral hernias found in 10% of the patient and nearly twice as common in girls. The family history is reported in up to 25% of children. What's the embryology? During the development of the testicles, there is pouch of the peritoneum. This pouch of the peritoneum called processus vaginalis. This processus vaginalis will proceed in front of the testicles during the second and the third months of gestation. Normally, once the testicular descent complete, there will be obliteration of the processus vaginalis, and it's called a remnant of the processus vaginalis. However, sometimes there is failure of the obliteration, and accordingly, if this tract is widely open and it can pass a loop of the bowel, it will result in inguinal hernia. However, it may lead to only presence of the peritoneal fluid or fluid around the testicles called hydrocele. So this is the basic principles of the development of inguinal hernia. The risk factors is very important. Is there is a risk factors or conditions associated with inguinal hernia? Yes. There are some and many conditions when there is increased incidence of inguinal hernia. Like, for example, prematurity, cystic fibrosis disease, the presence of the hydrocephalus, which necessitate the application of the ventriculoperitoneal shunt, in some cases of the peritoneal dialysis, and also some cases of genitourinary abnormalities, connective tissue disorders, abdominal wall defect, and glycogen storage disease. Pediatric surgeon and pediatrician should be aware of these conditions and should inform the parent of these children that they have a high incidence for the development of unilateral or bilateral inguinal hernia. We will speak briefly about the most common conditions. In the prematurity, it's common association due to interruption of the normal process of the testicular descent and also the presence of the associated comorbidities like chronic lung disease with increased intra-abdominal pressure, which may lead to the development of inguinal hernia. In cases of hydrocephalus, which need the application of ventriculoperitoneal shunt, there is associated incidence from 15 to 25. And also the inguinal hernia with this shunt more likely to develop in the neonate than the older children and more common in boys than girls. The average time from the placement of the shunt to the hernia repair around 5 to 12 months. In cystic fibrosis disease, it's very common association reaching up to 15% of the inguinal hernia. It's also a risk for the bilaterality and recurrence. Cystic fibrosis is a major risk for bilateral hernia and recurrent hernia. It may be genetic factors or mechanical factors, as these children usually have chronic lung disease, increased intra-abdominal pressure. It's very common in children with cystic fibrosis. There is associated vasal abnormalities like small or absent vas or vasal abnormalities should require evaluation from the pediatric surgeon. The congenital absence of the vas, also unilateral or bilateral, may be due to mutation in the cystic fibrosis gene or maybe an isolated entity or in association with renal anomalies. This laparoscopic view showing child with cystic fibrosis and bilateral atrophic vas on both sides. How to classify inguinal hernia? Is there a classification for inguinal hernia? Yes. The pediatric surgeon and the pediatrician should know that inguinal hernia include, number one, indirect inguinal hernia, the most common, and it is lateral to the inferior epigastric vessels. This is a laparoscopic view showing the opened ring lateral to the inferior epigastric vessels, and also in this diagrammatic view. The direct hernia is uncommon, which is a medial to in the inferior epigastric vessels, usually uncommon even for young adult. The femoral hernia, it's inferior to the inguinal ligament and form less than 1% of the pediatric inguinal hernia. However, it may be a misleading diagnosis and only diagnosed during operative laparoscopic view. During laparoscopic view, you can diagnose the femoral and it can be mistaken as direct hernia. Sliding hernia. What's the meaning by sliding hernia? Means that the viscera, the bowel, or the bladder or reproductive structure compose part of the hernial sac. So it is called sliding hernia. Also, there is a type which is called pantaloon hernia. This term derived from baggy trouser gathered at the ankles. So it consists of both indirect and direct inguinal hernias, usually common in the neonate, medial and lateral to the inferior epigastric vessels, pantaloon. Also, inguinal hernia term may include what's called amand hernia, meaning appendix in the hernial sac. And this appendix may get inflamed, and will be a swelling with manifestation of acute appendicitis. We will speak about this. Also, there is what is called Littré hernia, which is a Mickel diverticulum in the hernial sac, which may get inflamed or cause bleeding in a child from ectopic gastric tissue. Also, there is what's called Richter hernia. Richter hernia, it is ischemic antimesenteric bowel in the hernial sac. So still the continuity of the bowel is open, and this is one cases of intestinal obstruction with diarrhea. Usually intestinal obstruction or bowel obstruction manifest with vomiting, distension, and constipation. However, in these cases, bowel lumen is still open and there will be diarrhea with obstruction. So there is herniation of antimesenteric bowel border only, not the full lobe. How to diagnose? It seems to be an easy question. Hernia is a clinical diagnosis. However, the pediatric surgeon and pediatrician should take a good history and perform physical examination and sometimes radiology. So it's very important. The history usually given by the parent or the caregiver of the child, there will be asymptomatic, intermittent, unilateral or bilateral, reducible, if there is no complication, reducible inguinal bulge. The crying or coughing of the child straining will elicit the hernia. The suggestive history only and the normal examination is the commonplace in pediatric surgery clinic. And the picture documentation also is a commonplace for diagnosis, picture taking by the parent for the child with the inguinal bulge. The convincing history is considered by many authors as acceptable indication for surgery, especially with the development of laparoscopy, which help the definitive diagnosis and repair, and also the inspections for the contralateral side. There is some relevant element in the history which suggests the inguinal hernia, like prematurity, family history, genitourinary anomalies, presence or absence of these associated factors may be relevant during history taking. Sometimes there is a child with inguinal pain, but no history of bulge or swelling and normal physical examination. So the only complaint is pain with no history of bulge or swelling. In such cases, the sources like musculoskeletal strain, genitourinary causes should be excluded before operative intervention. And as we says, the presence of the diagnostic laparoscopy is useful in equivocal cases or equivocal examination in the presence of the persistent symptoms with no apparent cause. Physical examination. Reducible, if not complicated, inguinal or scrotal bulge, more prominent during Valsalva maneuver. The child can raise the head while supine or blowing up a balloon. In older children with a thumb in the mouth, standing of the child upright may help to demonstrate the hernia in older children. So any conditions that increase intra-abdominal pressure can elicit the hernia. There is what's called silk glove sign, feeling the second peritoneum of the patent processus vaginalis as the cord is palpated and it is examiner dependent, with more than 90% sensitivity in the experienced hand. In girls, hard mass, sometimes felt if the ovary protrude into the sac. So silk glove sign is important during physical examination of a child with suspected inguinal hernia. Radiological assessment, not usually necessary or helpful. Ultrasound can identify the patent processus vaginalis through widening of the internal inguinal ring, demonstrated by some authors as more than 4 to 5 millimeter considered positive, but the technique is highly operator dependent and not widely used in children. In few reports, ultrasound can be used to identify contralateral patent processus vaginalis. So the diagnosis of the inguinal hernia is mainly clinical one. The pediatric surgeon take a good history from the parent. The picture documentation is very important. The presence of the swelling and the examination by performing the silk glove sign or feeling the swelling using Valsalva maneuver, standing the child or flowing or increasing intra-abdominal pressure. The question, how to treat this inguinal hernia in children? The following items should be discussed. What is the ideal time for surgery? And what's the technique? Open inguinal hernia repair versus laparoscopic inguinal hernia repair. And what about the special circumstances for the treatment? And what is about the complications for or after repair? Pediatric surgeons should know well these items and how to deal. The first question, what's the ideal time for surgery? There is a golden statement that presence of the inguinal hernia is an indication for elective repair. You prepare the child, perform investigation, laboratory investigation, exclude anemias, exclude other diseases, and then go to the theater for elective repair of the hernia. Prompt repair may decrease the risk of incarceration. There is a Canadian study found that children less than 1 year of age had twice risk of incarceration when the repair performed more than 2 weeks after diagnosis. The debate is in the timing of the repair in the neonatal intensive care unit infant. This is widely variable in the literature and controversial, especially in the premature infant. So we have two problems. Infant in the neonatal intensive care unit, which is premature, also premature. What about the timing of the repair? Is it early or late repair? Ideal time for neonatal intensive care unit infant is divided in two schools. Early repair. Who advocate early repair, which means that repair performed shortly prior to the neonatal discharge from the NICU. They said that it's more technically demanding, it needs high recurrence, may have high recurrence and complication rate. Also, this repair, early repair, may prolong the mechanical ventilation and the length of the stay in the neonatal ICU. Also may be associated with increased risk of apnea and bradycardia. So this early repair, shortly prior to the neonatal discharge, may be more technically demanding, may have high recurrence, may prolong mechanical ventilation, and this stay may be associated with high risk of apnea and bradycardia. The late repair, second school, after 55 weeks post-conceptional age, increased risk of incarceration when you leave this infant for late repair, more frequent emergency department and clinic visit and readmission, Also potential failure of the family to follow up in some cases. So you can wait between these two options, early versus late repair. So early versus late repair in the premature infant. The concern about the long-term neurodevelopmental risk of the anesthesia, if proved, would favor the late approach. If proved that there is a concern or there is an effect on the long-term neurodevelopmental risk from using anesthesia in this premature infant. In recent database survey, about 40% of the premature infant underwent early repair, but variability between hospitals was significant regarding this point. So it is still a debatable item and debatable issue. Pediatric surgeon should know well this debate. The question is how to repair. And this is the work, actual work of the pediatric surgeon. Operative technique, open inguinal hernia repair, laparoscopic inguinal hernia repair, laparoscopic versus open. So the pediatric surgeon should answer these 3 points when you speak about how to repair. Open inguinal hernia repair, standard repair, well-known repair of inguinal hernia and the gold standard. Laparoscopic inguinal hernia repair, when to perform laparoscopy. And finally, the debate, which is better, laparoscopic versus open. We can see open inguinal hernia repair, all of us know that it relies on the high ligation of the hernial sac, and the proximal sac is carefully dissected and separated from the cord, divided, preserved the vas and vessels and the structures, and the distal sac widely opened. If there is no hydrocele, if there is hydrocele, it is evacuated. However, excisions of the hydrocele sac is not necessary by many authors. In the blind-ended sac, the entire sac can be resected after high ligation. There is a debatable items with open inguinal hernia repair, which is called contralateral patent processes vaginalis. Is there is indication for contralateral patent processes vaginalis evaluation during open inguinal hernia repair? Historically, open inguinal hernia repair on the other side to perform exploration on both sides. However, with the development of laparoscopy, the laparoscopy can be used, the telescope can be inserted at the time of the open inguinal hernia using a small scope inserted through a 2 millimeter port placed through the ipsilateral hernia after insufflation to look for the other side, contralateral patent processes vaginalis that might develop into an obvious hernia. However, the incidence is very low. However, it may develop into an obvious hernia, so you need or you try to diagnose the presence of the contralateral patent processes vaginalis so you can repair it during the same anesthesia. Indication is controversial. Some surgeons perform it in the premature infant, especially because of the high incidence of bilateral hernia in this age group. So they need to take a look on the contralateral side. Others consider it unnecessary or over-treatment as only 7 to 10% well-developed metachronous hernia on the other side, only 7 to 10%. So this is a debatable item, especially during open inguinal hernia repair. If during laparoscopy, it will be obvious. It's one of the advantages of the laparoscopy to look or inspect the other inguinal ring. However, the debate regarding open inguinal hernia repair, is it necessary to look for the other inguinal hernia or not. Controversial issue. However, some pediatric surgeons perform it, especially in the premature, because of the high incidence of the bilateral hernia. Others consider it as over-treatment. In a survey of the current practice of 395 members of the surgical section of the American Academy of Pediatrics, 44 reported that they routinely explore the contralateral side in boys less than 2 years of age. This is number one. Number two, 47% routinely explore the contralateral side in girls under the age of 4 years. This is the current practice reported regarding the surgical section of the American Academy of Pediatrics regarding the contralateral exploration or contralateral searching for patent processus vaginalis. It has been suggested that ultrasound may be a good technique to show if there is contralateral patent processus vaginalis, as the diagnostic accuracy is high and it is non-invasive. Laparoscopy is highly sensitive in detecting contralateral patent processus vaginalis. Although a contralateral patent processus vaginalis is shown with laparoscopy, most patients don't develop a hernia after ipsilateral repair. Therefore, finally, the contralateral patent processus vaginalis exploration is not considered to be justified. So this item or this debatable item should be fully understood by the pediatric surgeon and pediatrician. You should know and understand this debate to look or not to look, to perform laparoscopy, to perform inguinal exploration. Is it validated procedure or not, with a very low incidence of the development of metachronous hernia after ipsilateral repair? So you should weigh the benefit and the risk of this procedure. Then we will go to the second items, which is laparoscopic inguinal hernia repair. Second technique for repair. We speak about the open, then the laparoscopic. All of us know the advantage of the laparoscopy. The first, or number one, is visualization of the contralateral patent processus vaginalis. We speak about it during open. Number two, identification of the less common hernia, like direct femoral pantalon hernia. The laparoscopy is excellent in diagnosis of this least common type. Number three, less postoperative pain, rapid return, and improved cosmesis. Okay, however, the disadvantage to perform laparoscopic inguinal hernia repair, possible increased length of the operative time. And definitely there is a learning curve to perform laparoscopic inguinal hernia in infant or a child. Number two, definite learning curve. Number three, the need for orotracheal intubation for anesthesia. And there is maybe some debate about using anesthesia, especially in the young infant and children. Laparoscopic inguinal hernia repair in infant. Less postoperative infection. Some authors reported that there is less postoperative wound infection, as laparoscopic scars located higher compared with open inguinal hernia scar inside the diaper area subject to urine or fecal contamination. A debatable items may be theoretically right. Report found fewer wound infection after laparoscopic inguinal hernia repair versus open in infant of similar age. O or 0 versus 2.3 infection. Number two, the disadvantage of the laparoscopic hernia repair in infant, the limited working space. As all of us know that when we're using laparoscopy, we will depend on idea called triangulations between the camera and the working board. We need to perform triangle so the pediatric surgeon can manipulate the tissues and movement of the instrument and can move the instrument without crashing of the instrument. In infant, there is limited working space from bowel distension. However, it can be helpful to perform bowel preparation before the day before the operation to empty the intestinal loops and to create working space. However, there is still limited working space because the size of the abdomen is small. As we see, this is obviously the triangulation needed for efficient laparoscopy. This triangulation, this is the working camera and the working board. So there is a triangle pointing at the subject needed to be repaired. However, no true triangulation in a small infant between the telescope and the two operative port sites as they located higher than usual, usually on the umbilical plane, at the same level as the telescope present, so there is no true triangulation. So this is one of the limitations for laparoscopy in infant. Limitation due to absent or no true triangulation. There is no space to perform this triangulation. So usually the working instrument will be placed higher than usual, exactly at the umbilical plane, at the same level of the camera. So there is no triangulation. They will be at the same level, not like this picture. Then we will speak about the laparoscopic inguinal hernia suturing technique. We know that the laparoscopic inguinal hernia repair depend on the creation of the purse string around the internal inguinal ring from inside, whether with separation of the peritoneum using the dissection methods or with intact purse only. There is modifications, and you can ligate the suture inside or outside the abdomen. So there is what's called intracorporeal technique. Mountbett in 1993 described the purse string sutures around the orifice of the internal inguinal ring, and the purse string tied intracorporeal, and the hernia is closed, like the second picture. This is intracorporeal technique. Shire, 1998, described N-shaped. Unlike purse string, modified the suture to be N-shaped and suture it and tied intracorporeally, and also the hernial sac is closed. In 1999, Mountbett and Espoto modified the two important aspects of the technique. Before closing the defect, the periorificial peritoneum around the internal inguinal ring is cut with monopolar cautery, and non-absorbable sutures is used to repair the hernial defect. On the other hand, we can use what's called extracorporeal technique. Placement of the suture circumferentially around the internal inguinal ring and tying the knot using percutaneous technique. Many variations described for this extracorporeal technique. However, Ostel and Poneski reviewed the literatures and stated that there was insufficient evidence to support one approach over another. The major debate: laparoscopic inguinal hernia versus open inguinal hernia repair. Which to choose for the repairment of the inguinal hernia? It's widely debated subject in the literature. Advocate of the laparoscopic inguinal hernia cite many advantages. On the other hand, recent inguinal hernia literature describe outcome following open inguinal hernia is scanty, and the real incidence of the complications after open inguinal hernia may be underestimated. So there is a major debate. We will go deeply through this debate, and all pediatric surgeon and pediatrician should understand this debate very well. Advocate, who advocate laparoscopic inguinal hernia, cite better visualization, yes, no debate, of the vital cord structure, thereby making dissection more safer. Number two, no dissection of the abdominal wall or the cord structures, theoretically reducing the risk of the testicular atrophy, secondary cryptorchidism, or other complications. Less intraoperative complications as bladder injury or rupture that may happen during open surgery due to improved visualization of the anatomy. Identification and the treatment of contralateral patent processus vaginalis, present in up to half of the patient, particularly the younger one. 90% of the parent desired to have repair of the contralateral patent processus vaginalis at the same setting. When you ask the parent if you would like to repair the contralateral patent processus vaginalis, they will overwhelmingly agree to perform this procedure and close the other side during the same anesthetic levels. So it can be performed with laparoscopy. So this is one of the advantages of laparoscopic inguinal hernia repair. However, we can't reach a definitive separation when we speak with two surgeons. One advocate laparoscopic inguinal hernia and one advocate open inguinal hernia. So there always will be a debate between both of them. So to be scientific and perform something related to accuracy, to perform something related to evidence-based analysis, to clarify the real impact of the laparoscopic inguinal hernia in pediatric, authors reviewed 90 studies and reported the following. They reviewed these studies and compare between both techniques. Number one, operative technique. The first question, is there a difference between the operative time between open and laparoscopic? Yes, it's varied widely, depending on the technique and the operative experience of the surgeon. The average operative time for the open inguinal hernia of unilateral case was 30 minutes versus 23.7 minutes via laparoscopy after training curve, after learning curve. In most laparoscopic inguinal hernia studies, there was no conversion. So this is the first item for comparison, is operative time. Open versus laparoscopic, after reviewing these 90 studies. The recurrence rate. Authors seek about the recurrence or search about recurrence. The mean recurrence rate were similar between open inguinal hernia repair and laparoscopic, both ranging from 0 to 6%. In infant, the recurrence rate seemed to be higher after open inguinal hernia repair compared with laparoscopic inguinal hernia repair. Number three, the wound infection. We speak at first presentation about the wound infection. Postoperative hydrocele, iatrogenic cryptorchidism, testicular atrophy were significantly higher after open inguinal hernia repair than after laparoscopic inguinal hernia repair. Number four, rare hernia identification. In laparoscopic inguinal hernia studies, incidence was 0.3 to 7.2. The most common was direct hernia, femoral hernia, pantaloon hernia, combination of indirect with the femoral, indirect with direct and femoral, amandlitary hernia diagnosis. On the other side, during open inguinal hernia repair studies, no rare hernias were reported. Contralateral patent processus vaginalis, as we said, 23 studies reported coexistence of the unilateral inguinal hernia with contralateral patent processus vaginalis for highly variable incidence between 19.8 8 and 66. Most contralateral patent processes vaginalis were repaired in the smaller infant. So this is in the side of the laparoscopy advantage. Finally, to get out of this confusion, the authors summarized that. Number one, no definitive conclusion in the current literature about which technique, open laparoscopic, is preferable for inguinal hernia repair in infant and children. So what to do? The pediatric surgeon should inform the parent that two different approaches exist and explain to them and be aware of the advantage and the disadvantage of each option. So after this debate or major debate, there is no final conclusion to support one over the other. No definitive conclusion in the literature up till now, which technique preferable, because one technique show advantage and disadvantage, other technique show advantage and disadvantage. So you should be fair and explain to the parent that we have two approaches. The first is laparoscopic, the second is open, and explain each procedure, what are the associated advantage, associated complications for such approach. Now we will speak about some special circumstances that may face the pediatric surgeon during dealing with inguinal hernia. Number one, hydrocele. Is it managed like hernia or differently? Number two, incarcerated hernia. Not reducible hernia, it's into incarceration. Number three, special hernias. How to deal with direct pantaloon and femoral shortly. Number four, incidental diagnosis of patent processes vaginalis. You perform laparoscopy for another procedure, not hernia, and you incidentally faced with patent processes vaginalis. The disorders of the sexual development associated with hernia, inguinal hernia, what's called adrenal wrist or splenogonadal fusions, acutely inflamed appendix in the inguinal hernia site. We will go rapidly through these items. Hydrocele. You should divide hydrocele in two, whether non-communicating hydrocele, no communications with the peritoneal cavity. Most surgeons, if there is non-communicating, will observe and manage expectantly until the child reaches 1 to 2 years of age. In the absence of evidence of the communication, no communication indicating obliterated processes vaginalis. We will show the communicated one. How to identify communication? Number one, development of the new hydrocele after birth. Number two, which is very important, waxing and wanting in the size. What's mean? Changing in the size, enlarging and decreasing in the size of the fluid collections, and failure to resolve by 1 to 2 years of age. So the mothers of the child may say that the size of the hydrocele is fluctuating. Early morning, it will be decreased with the sleeping of the child. However, with activity, daily activity of the child, at the end of the day, will be large hydrocele, indicating there is a communicating hydrocele. How to treat communicated hydrocele? It's also controversial. Some surgeons advocate treatment as hernia and repair electively. If there is evidence of the communication, waxing and wanting in the size of the hydrocele during the day. Other surgeons advocate observation and expectant management as this fluid will reabsorb. The survey of the North American pediatric surgeon, 1996 to 2003, found that observation preferred by only 1/3 in 1996 and 54 in 2005 to observe communicated hydrocele. Survey in the UK, 2017 noted that about 61% of the pediatric surgeon and urologist didn't differentiate between communicating and non-communicating hydrocele, and most deferred the repair until 2 to 3 years of age. About 61 of the pediatric surgeon and urologists don't differentiate between communicated and non-communicating, and all will delay the repair until the child is 2 to 3 years of age. Very important for pediatric surgeon to be aware of this debate. The resolution of the apparently communicating asymptomatic hydrocele reported up to 60 to 90% of the cases. Laparoscopic inguinal hernia approach can be used in the case of the communicating hydrocele. In this patient, the fluid is aspirated and the patent processus vaginalis closed with either intracorporeal or extracorporeal technique. Second type is called hydrocele of the cord. There is obliteration of the proximal and the distal processus vaginalis with retention of fluid filled sac along the spermatic cord. On examination, there will be smooth, sausage-like mobile mass palpated in the inguinal canal. The treatment, it may be difficult to differentiate from incarcerated hernia in irritable and crying baby who undergo attempt of reductions by other examiners. The treatment is controversial, also with some favoring operation and others favoring observation. There is what's called giant hydrocele, and it will be annoying to the parent of the child. However, giant hydrocele, there is no objective definition. Considered as indications for operation by some surgeon, even without the evidence of the communication. However, the major drawback is the recurrence of this hydrocele in many cases. There is what's called also abdominoscrotal hydrocele. It's a rare entity or unusual entity. There is a large scrotal mass with inguinoscrotal and abdominal component in a dumbbelled configuration, like this picture. Springing back pool sign, it's cross fluctuation when you compress the scrotal component, cause protrusion of the abdominal component, and vice versa. Laparoscopy can be confirmed for such cases. The treatment for this condition range from aspiration, observation, inguinal exploration, combined inguinoscrotal and laparoscopic approach. There is adolescent hydrocele, mostly non-communicating. The history and the examination can exclude communication. If no clear cause is identified, ultrasound is performed to exclude maybe presence of testicular tumors. Transscrotal hydrocelectomy is appropriate in adolescent in the absence of signs of patent processus vaginalis or tumor. The second, special circumstances. The pediatric surgeon should be aware during repair of the inguinal hernia is incarcerated inguinal hernia. It can be difficult to differentiate from hydrocele of the cord. However, happy baby with no tenderness suggests hydrocele. But if several examiners vigorously attempt to reduce the hydrocele, the differentiation can be difficult and ultrasound may be helpful. So please don't vigorously examine the child present with bulge or swelling in the inguinal region, because you will mislead the pediatric surgeon for the diagnosis. The treatment for incarcerated hernia, number one, trial of reduction. Trial of reduction, however, it's contraindicated in the presence of peritonitis, hemodynamic instability, or shock, relative symptoms of the bowel obstructions. So there is contraindication to try to reduce incarcerated hernia. Also, The technique, you should monitor the child with using of sedations, firm and continuous. Pressure is applied around the incarcerated hernia. Successful reduction confirmed by the sudden poop of the content back into the peritoneal cavity. However, take care of what's called reduction in mass. The hernia content are reduced into the peritoneal cavity, but the bowel remained incarcerated internally in the hernial sac. Very rare, but the surgeon should be aware of this possibility. So please don't overwhelming press over the hernia, so you may lead to reduction in mass. After reduction of the incarcerated hernia, if it's reduced easily, some surgeons recommend delay of 24 to 48 hours before operation to allow resolution of the edema prior to the open hernia repair. It's historically recommended. Delay is less important if laparoscopic inguinal hernia repair is planned, because you repair from above the edematous area. Reliability of the family, as well as the clinical history, very difficult reduction, and geographical consideration. The absence or the difficulty for the family follow-up may indicate the need for admission and observation before definitive repair. In some children, you need to observe and admit the child before repair, depending on some special circumstances. It's estimated that 70 to 95 of incarcerated hernias can be successfully reduced. However, in one report, 743 incarcerated hernia, only 8% required emergency surgery, and 2 children required bowel resection. An urgent operation is necessary if the reduction of the hernial content unsuccessful or incomplete, or you suspect reduction in mass. Operative approach for incarcerated hernia may be laparoscopic approach or open approach. Laparoscopy for incarcerated hernia, some authors prefer it. On occasions, the hernia may spontaneously reduce with induction of the anesthesia. If the laparoscopy is planned, it should be proceed. So in some cases of the incarcerated hernia, after anesthesia on the operating table, the hernia reduced spontaneously. If you plan to perform laparoscopy, you should proceed. Using laparoscopic gentle traction and manual external pressure, it's usually possible to reduce the incarcerated hernia content. Once the hernia content are reduced, the repair is performed as standard. The intestine or the appendix can be externalized through the umbilicus for examination or to perform bowel resection or appendectomy if necessary. So you gently apply traction, external pressure, you gently examine the bowel for viability after reduction. If you need resection, if you need examinations, you can protrude the intestine or the appendix through the umbilicus during laparoscopic repair of incarcerated hernia. The open approach for incarcerated hernia, there is some special observation the pediatric surgeon should take care. The bloody fluid or the enteric content from the open sac mandate additional investigation and the inspections of the peritoneal content. Laparoscopy can be inserted through the sac or through the umbilicus to evaluate for the intestinal injury. Separate incisions may be needed in the transversalis through the semi-inguinal skin incisions above the internal inguinal ring. So this bloody fluid or enteric content passing away from the open sac is a dangerous sign that there is maybe strangulated hernia, maybe intestinal injury. So the pediatric surgeon should inspect the peritoneal content, whether to open to you above, to widen the incision, to use separate incision, to use laparoscopy. If the bowel is still incarcerated after general anesthesia, induction, the sac is opened and the viable bowel reduced, then standard repair is done. Hernial sac usually quietly edematous and friable, and hernia repair can be quite difficult in such cases. It may be necessary to open the internal inguinal ring directly in order to reduce the bowel. Sliding hernia is more frequent in incarcerated hernias, particularly in girls. Ischemic intestine can be resected and anastomosis performed whether through the inguinal incision, laparoscopic, or opening abdominal approach. Even with incarceration, the intestinal injury requiring resection is rare, reported only in about 1 to 2%. Post-operative complications, the parent should be counseled preoperatively in cases of incarcerated hernia about the risk of recurrence, wound infection, testicular loss, or vas injury from incarceration effect on the blood supply of these end organs. Incidence of testicular atrophy about 2 to 3%, like in this blackish discoloration of the testicles in case of incarceration. So the parent should be counseled and informed about this possible complication. Incarcerated hernia in girls, ovary and fallopian tube commonly involved. If the ovary is incarcerated in asymptomatic infant, its blood supply usually unaffected. However, most pediatric surgeons promptly, not urgently, repair the hernia. Ovary is more likely to be compromised from torsion, unlike compression of the vessels with incarceration. So this is also a debatable items or special circumstances, which is incarcerated hernia. Special hernias, direct inguinal hernia. It's rare even in older teenager. It's about 2 to 4% in large laparoscopic series where they are most readily detected during laparoscopy, often unrecognized preoperatively. Some recurrence after indirect repair are direct inguinal hernias. How to treat? We can perform open McVeigh repair, Pacini, or with mesh, or laparoscopic repair. And during laparoscopy, you can refer to the textbook, operative textbook for more details. There will be large lipoma adherent to the sac and reduction of the lipoma, followed by excisions using hook cautery is recommended. Defect closures with several interrupted non-absorbable suture and use of vestigial ligament to reinforce and the closure of the defect without tension. Pantaloon hernia, it's combination, as we said, of the direct and the indirect hernia, or combination of the all, indirect, direct, and femoral. It's rarely found in children. Laparoscopic approach is the optimal way to identify and treat this type of hernia. Femoral, it's rare, 0.2 pediatric hernia. Bilateral in 10 to 20% of cases, relatively equally distributed by gender, with a mean age at diagnosis of about 5 to 7 years. Most are not suspected before the operation, difficult. Mass medial to the femoral vessels and below the inguinal ligament should alert the clinician to this possibility. Often not identified with open inguinal hernia and incorrectly treated as indirect hernia, as we see after open inguinal hernia repair. For right inguinal hernia, non-absorbable sutures at the right internal inguinal ring. Inguinal bulges still persist. Diagnostic laparoscopy show right femoral hernia present after repair of the closed after repair of the right internal inguinal ring. There is still bulge, and the laparoscopy show right femoral hernia. How to treat the femoral hernia? Dench series evaluate 970 adult femoral hernia repair and found that laparoscopy had a lower risk of the reoperation compared with open repair. Small pediatric series also show the low recurrence rate as well. Open repair with mesh or mesh plug or Cooper ligament McVeigh repair are alternative to the laparoscopic repair. And you can refer to operative textbook for more details about these repairs. Incidental patent processus vaginalis diagnosed in a child undergoing laparoscopy for unrelated problem. Appendectomy, and the pediatric surgeon incidentally diagnosed patent processus vaginalis. What to do? In a series of about 1,548 infants and the children found that incidence of patent processus vaginalis was 20%. 13% of those with incidental patent processus vaginalis developed clinical hernia, and at mean of 9 months from the original laparoscopy. How to treat? The pediatric surgeon should inform the family about the finding, and most pediatric surgeons recommend observation for incidental asymptomatic patent processus vaginalis. This is incidentally patent processus vaginalis during laparoscopy. Regarding disorder of the sexual development, there is a condition called complete androgen insensitivity syndrome, which means it's commonly associated with inguinal hernia. It's normal female appearance and external genitalia with XY karyotyping. It's rare. Incidence in the pre-menstrual girl with inguinal hernia may approach 1 to 2%. Young girl in these pictures undergoing right open inguinal hernia repair with manipulation of the sac, testicles identified. This child had complete androgen insensitivity syndrome. How to treat this problem? The abnormal gonad in the hernial sac should biopsy and preserve it. Phenotyping, androgen receptor gene determination, and abdominal ultrasound may be helpful. Laparoscopic hernia repair allow identification of the intersex abnormalities, presence or absence of the fallopian tube, ovary, and uterus. So laparoscopy here is important. There is what's called adrenal rest, incidentally discovered yellow nodule along the spermatic cord or the testicles. In one study, the incidence was 1.7 in 1,862 pediatric hernia repair. It should be removed if possible. Splenogonadal fusion, it's rare entity, difficult to differentiate preoperatively from a neoplasm. It may be continuous, band attached gonad to the spleen, or may be discontinuous in the scrotum only. The frozen section confirmation is useful. Gonadal preservation is important. Acutely inflamed appendix in the hernial sac, it's extremely rare. Usually presented with crampy, dull, lower abdominal pain combined with irreducible and tender mass in or near the inguinal canal. Because of the non-specific presentation of the pain, the diagnosis of appendicitis is rarely considered. The laparoscopic approach is safe in these cases and effective for the treatment of this rare finding. Now, we will go to the complication of the repair of inguinal hernia. This is the final section of presentation today. It's relatively infrequent. Parents usually concerned about the bruising and swelling in the scrotum, labial regions, but this is transient and minor. However, on the other hand, there is a complication. The pediatric surgeon should be aware about it. Number one, large scrotal hematoma or seroma, residual asymptomatic hydrocele, recurrent hernia, injury to the vas or testicle, iatrogenic cryptorchidism, postoperative, chronic pain after surgery, and finally mortality. These types of the complications that the pediatric surgeon should be aware how to diagnose and how to manage. Parents usually aware about bruising, swelling of the inguinal regions or the scrotum, which is a minor and transient. We will go through each one separately. Large scrotal hematoma or seroma can compromise the blood flow to the testicle, so take care. Doppler may define the nature of the swelling and evaluate for ischemia. Hematoma should be evacuated if there is evidence of impaired blood flow to the testicles. This is number one. Number two, residual asymptomatic hydrocele. It's common, especially after large hydrocele. Most will finally reabsorb. If persist for 6 to 12 months, aspiration may be indicated. Only rarely formal hydrocelectomy is required. Recurrent hernia, seen in less than 2% of repair in the absence of predisposing factors as prematurity, incarceration, disease that increase intra-abdominal pressure, connective tissue disorders, teenager patient, cystic fibrosis, ventriculoperitoneal shunt, and ascites. Most authors advocate laparoscopic repair for recurrent inguinal hernia due to technical difficulty and risk of injury to the cord structures during open repair, because you operate in a scarred, previously operated inguinal canal. Number two, the operative time are reduced and complications have been minimal in several small series. Laparoscopy likely the best approach to identify and treat causes of the recurrence. So here, laparoscopy taking the upper hand over the open inguinal hernia repair for recurrent hernia treatment and diagnosis for the cause of recurrence. Injury to the vas or the testicles, it's rare, both under 1%. In Ian's personal series of 6,361 open inguinal hernia repair, vasal injuries were found in 0.6 per thousand. Testicular atrophy was noted in 0.3%. Incidence of the vasal injury may be underestimated, as instrument manipulation of the cord may cause microscopic injury and scarring in animal models. So this microscopic injury and scarring may not be diagnosed clinically in children. Long-term follow-up after laparoscopic repair is not yet available. In open era, a review of 7,314 inguinal hernia specimens found either a vas difference or epididymis in 0.53 of the specimen. However, some of these may represent remnant rather than true injuries. So the incidence or the true incidence of the injury may be underestimated due to these factors. Male infertility or obstructive azoospermia. In adult meta-analysis, there was no evidence of association between prior inguinal hernia repair without mesh and male infertility or obstructive azoospermia. Controversially, in a series of adults who have obstructive azoospermia, pediatric inguinal hernia repair are a common cause. So it's debate, or there is a controversy between the diagnosis from this side and the diagnosis from the other side. Iatrogenic cryptorchidism, or what's called ascending testicles. It's infrequent complication. Wang et al. Reviewed over 17,000 pediatric inguinal hernia repair, open and laparoscopic, found the incidence of 0.058% attributed to adhesions of the cord that fix the testicles in position, and usually reoperative orchiopexy usually required. Respiratory insufficiency. Respiratory insufficiency as a complication of inguinal hernia repair? Yes. In a small infant with very large inguinal hernia may have respiratory insufficiency from the loss of the abdominal domain after bowel is reduced into the abdomen. So the pediatric surgeon should be aware about this. Although uncommon, should be taken in consideration, particularly in neonatal intensive care unit infant with large hernia who are already oxygen or ventilator dependent. The staged repair of bilateral hernia may be necessary in such patient. Chronic pain after inguinal hernia repair, recognized in adult in about 10 to 15%, but less common in children. Few studies assist what's called inguinodenia in children. In 2 studies, incidence about 5%, which is half of the incidence in adult. Finally, mortality. Catastrophe. Child with inguinal hernia die postoperative. It's directly related to inguinal hernia or its repair is extremely rare, less than 1%, and we hope it will not happen to any infant or child. So our subject today is very, very important. Inguinal hernia in infant and children, a very common presentation in the outpatient clinic. All pediatric surgeon and pediatrician should be aware about this disease. We speak about the brief history about hernia, the incidence, the associated conditions with inguinal hernia. What is the meaning of the inguinal hernia? The term include 1, 2, 3, 4. The presentation, how to diagnose, how to treat inguinal hernia. Open, laparoscopic versus open, which is better. And also, it depends on the age. Infant, neonatal intensive care, premature. Many debates related to these items. Pediatric surgeon and pediatrician should be aware of these items to deal correctly with this condition. Then we go through the special circumstances. There is a hydrocele, not hernia. Communicating, non-communicating, giant, abdominoscrotal hydrocele, adolescent hydrocele. Then we go through incarcerated, the hernia content not reduced, trial of reduction with its contraindications and complications of reduction. How to treat incarcerated hernia, laparoscopic or open, advantage of which. Then we go through other circumstances. There is rare hernias, identifications, and how to treat. There is maybe special circumstances related to the sexual disorders, related to the splenogonadal fusions. Pediatric surgeons should know the difference. And finally, we speak about the complications after the repair. Parents usually concerned about edema, seroma, bruising in the inguinal region or the scrotum. However, it's usually transient and minor. Our pediatric surgeon should be aware about scrotal hematoma, large hematoma that may compress the blood supply to the testicles, should be aware about the cryptorchidism or ascending testicles, should be about the injury to the vas or testicles. Pediatric surgeon should be about the incidence if there is report of the obstructive azoospermia or male infertility in adult, should be aware about the respiratory compromised in small premature infant with a large hernia. Pediatric surgeon should be aware about rare cases of inguinal pain, rare cases of mortality. And the main theme is difference or is laparoscopic versus open, debatable item up till now. We put an objective analysis related to more than 90 studies. The pediatric surgeons and the authors searched about operative time, searched about the rare hernia identifications, searched about the skin infections, the cryptorchidisms, identification of contralateral patent processus vaginalis, the identifications of these items, and finally conclude that there is no definitive conclusion to put one type of repair above the others, and the pediatric surgeon should inform the parent about the presence of these techniques. I hope the presentation is beneficial and useful for all pediatric surgeons and pediatricians, and many researchers is going up till now regarding the inguinal hernia in infant and the children. And pediatric surgeons should be fully aware about this condition. I hope the presentation is helpful for all pediatric surgeons and pediatricians. You can refer to operative textbooks for more operative details. I tried to summarize the subject because there are many details related to each point. However, I tried to summarize during the title during this short presentation. I hope it's beneficial for all pediatric surgeon and pediatrician. Thank you very much for your watching, and I will see you next in next subject of pediatric surgery made easy. Thank you very much.